Thank you, everyone, and welcome to the first Nightingale Challenge webinar of the year 2024. As some of you may already know, these webinars have been selected. The topics have been selected by early career nurses, and they are targeted for giving early career cancer nurses the basic information and knowledge that they need in specific topics of their interest. As I said, today is the first Nightingale Challenge webinar of 2024 about the year. This first one is on stem cell and bone marrow transplantation. Next one will be scientific writing and dissemination, and the last one is promoting well-being of cancer nurses, all of them with key speakers that we hope you enjoy. To begin with the first webinar, we have two guest speakers, both of them experts in the field of stem cell and bone marrow transplantation. After each presentation, you will be able to ask questions to the speakers, and they can directly ask those answer those concerns to you as well. But without further ado, let me introduce you our first speaker. Her name is Anne King Summerlin. She has been practicing in oncology nursing exclusively since 1993. She graduated from Troy State University in Alabama and went further to earn her master's degree in nursing administration and consultation from Troy University. She deepened her knowledge in nursing by earning a degree in family nurse practitioner program in Birmingham, and she began her nursing career at Baptist Medical Center South in Montgomery. At the time, she had the opportunity to work as director of medical nursing, and she has also became the director of nursing of the Montgomery Cancer Center. Currently, she is working as a nurse practitioner in the bone marrow transplant unit at City of Hope in Atlanta, Georgia. So welcome, Anne, and thank you so much for providing us with your expertise today. I'll now give you the room to share your presentation, and she's going to be talking from novice to expert. Give yourself time, a quick overview of oncology nursing for early career cancer nurses.
Good morning, or is it afternoon or night? In any event, my name is Anne Summerlin. Can everybody hear me okay?
Yes, we can hear you.
Okay, all right. Am I changing my slides or is somebody else doing that?
I'll do that for you.
Okay, perfect. Okay. So I wanted to start off simply by talking about maybe the stages of clinical competency, probably before anybody decides to become a nurse. Maybe what I should have started with is that there are plenty of options, and you have to know that there's a lot of information to learn. You kind of need to know that going to school and working may not be the best option for you if you're trying to earn a nursing degree. So you look at your resources that might be available, whether it's your state, who may pay the last 2 years of your nursing education, or other sources of finances. But nursing is a tough field, and it actually gets, I think, a little bit more challenging as the time changes. Without trying to tell you guys exactly how old I am, in trying to give an overview of oncology nursing, back in the day when I started, we probably had maybe 50 or 60 drugs to memorize, or to learn. I won't say memorize, but they were only, there were so few that we could memorize them, learn all the side effects, place them in categories of how these drugs acted, and everybody was pretty much comfortable with that. As it stands right now, there are probably 300 to 400 new drugs or oncology drugs out there. Side effects are kind of all over the place. We've moved from stem cell transplant or bone marrow transplant into a new era of cellular therapy, which truly complicates what the nurse is responsible for knowing and perfecting. So let's talk about stages of clinical competency or clinical competencies. I kind of listed stage one, and this is from a review of the literature, actually with a nursing colleague that I train with, but she had stage one as novice. So this is the nursing student who may be in his or her first year of clinical education. You already know that for the most part, most nursing programs, that first 45 hours is to make sure we can get people to become very well-rounded. You're taking English classes, history classes, all of the prerequisites before you start your nursing education. So when we say novice, a novice is a person that has very limited ability to predict what might happen. You know, you have to start somewhere. And for us, we're starting at the very beginning. You know, we are, for the most part, trying to learn about our own emotions and how we handle the continuum of health and illness and being a caregiver. So going from novice to expert is going to be a little bit different for everybody, but I would say on an average, anywhere from 18 months to 24 months, depending on the field a nurse chooses to go into. It may take you that long to become competent, let alone expert. So I don't want to necessarily put a time frame on. Now I finished nursing school, I passed my boards. When do I get to know everything? That's going to depend on how well it's going to depend on a lot of things: training, orientation, the setting that you're working in, outpatient versus inpatient, etc. So stage two, advanced beginner. These are new grads in their first job. Nurses have had more experience that enable them to recognize recurrent situations. You know a fever. You know what we do with a fever. You know that somebody having an elevated temperature, depending on, they may present with one or two symptoms. They may present with an entire cascade of symptoms. But you know enough to know that you need to let your APP or physician know that I have somebody who is unwell. You know to check a blood pressure if they have an elevated temperature. And you even know to go back and repeat those vital signs once you've done an intervention. So you have some knowledge and the know-how, but not enough in-depth experience to kind of do some critical thinking and think about why the different whys of the fever. So stage three is competency. These are nurses that pretty much lack the speed and flexibility of being a proficient nurse. They hadn't exactly gotten to the point where they can do holes instead of parts. They're still analyzing different things, but they do have mastery and can reflect on those other two steps, advanced beginner and novice, in terms of organizational skills. They begin to think on a continuum. So competent nurses recognize patterns and nature of clinical situations more quickly and accurately than advanced beginners. The proficient nurse, by nature of what we're saying, at this level, nurses are capable to see situation as wholes as opposed to just a part of a problem. They're able to put the pieces together. And in just a little bit, I'm going to use neutropenic fever to kind of explain these 5 stages and show you or explain to you maybe how a new nurse may look at a fever as opposed to a nurse who's very proficient and very comfortable with assessing what he or she needs to do with a patient who maybe does not have a white blood cell count, who may be pre or post transplant, and what to do with that fever. Expert nurses, these are nurses who are able to recognize demands and resources. These are people that probably have some time in the field, more than 2 years, more than 3 years, more than 10 years. And they are able to put together the pieces of the puzzle pretty efficiently, and by efficient, critical thinking wise, as well as time management wise. And we all will get there. Am I correct in understanding that most of our crowd are very new nurses? Is that
Yes, the majority of our nurses would be
Okay.
early in their career as cancer nurses, at least new to the
Okay.
oncology.
But everybody that is that's in the webinar, they are nurses, correct?
Yes, correct.
Okay, perfect. Okay, so next slide, please. Okay, so and I am working with, I would say, not novice nurses, but advanced beginner nurses who are competent as nurses, but maybe not competent in oncology nursing, and certainly not competent as stem cell transplant nurses. So for the last 9 months, we have been educating these staff members about bone marrow transplant, stem cell transplant. We are talking about maybe what fever looks like in our patient population. We are educating and training them on oncology nursing. And these are nurses who have been nurses for a while, but they've just never done this type of nursing, and it's very different. So the very first thing that we talk about in our training is time management. Years ago, when I got out of school, you know, you had orientation for 6 weeks or 8 weeks, and you got out, and somebody out there in the world thought that you were ready to go on the floor and begin practicing. Trust me, it's okay. Now we all know that we need to rethink that concept of how we teach and train our new nursing staff. Competency, we touched on that just a little bit. There are different ways to measure competency. And as a new nurse or a nurse going from one job to the next, you need to be able to identify what your strengths and weaknesses are, what your skill set, what your current skill set is, and what this job is demanding, and make sure that up front, you're able to discuss that with whoever's providing your orientation and training, or if you have a mentor, if you're assigned a person that's going to be following you the first 6 months or the first year while you're in the program, make sure that you're having this type of conversation with that person every 3 months. The organization that you're working for may or may not be set up to have an evaluation period where you have a 30-day, 60-day, or 90-day evaluation. But that is the one way to make sure you're getting feedback on competency and skill set. Communication skill. Probably for me as a new nurse, this was maybe the most difficult. And you need to practice what you're trying to convey to a physician, to a patient, to a nurse practitioner, or even to your seasoned nurse or your mentor. Practice what the question that you're trying to answer. Ask. Sometimes we know exactly what information that we're trying to seek, but we have difficulty conveying that question. So you got to practice, you know. Hopefully, none of you will run into nurses like I had back in the day when they say, well, just do as I say and don't do as I do. Hopefully most of those folks have retired, or either they have learned that is not the way to teach and train somebody. The next thing is stress management. I think no matter what part, what area or arena of nursing that you're doing, there's a certain amount of stress involved. If you look at the literature, nurses working in NICU seem to have maybe the highest stress level, followed by probably labor and delivery and ER. And oncology nursing is probably right along in that same arena, maybe ranking as 5 or 6. Confidence. Know that confidence is something that as a nurse you're going to build over time, no matter what practice arena you're working in. So let's talk about let's go back to that novice nurse and just look at how do we make sure that we don't lose this new nurse before she gets started. And if I had to assess when burnout takes place, I'm sorry, if you move to the next slide. So, right, strategies to incorporate. So, with the novice nurse, when we're looking at stages of clinical competency, with that novice nurse, what is the best way not to lose that nurse, or what kind of strategies can that novice nurse kind of employ to make sure that you stay kind of sound? And probably the first thing you need to do is assess your skill set, but also make sure that you're doing some self-care kind of things. And I teach this always to very new nurses, because we're so busy trying to learn, trying to take care of the patient, the family, that oftentimes we forget to take care of ourselves. And as a new nurse, with a novice nurse, I kind of find that is a huge issue. You want to make sure that you are a safe nurse so that you don't hurt anybody. And you can, I'm so sorry, you can work on this goal every day by asking yourself 2 questions. Why am I giving a medicine? Why am I doing this procedure? Why am I providing this intervention if you're actually in the workplace? And then you want to know, what will each medicine or procedure intervention do to the patient, and what are the possible complications? That's the kind of thinking that you have to employ when you're talking about moving from being a novice to an advanced beginner, to being very competent, to being proficient, to being expert. And again, knowing how to clearly and concisely talk to the APN or a physician so that you're advocating for the patient. If you don't know how to ask a question, it's going to be difficult for you to advocate for the patient. And you can use your preceptor by practicing with your preceptor. You know, as simple as, if I want to know why we're doing, why we're using this drug as opposed to what I learned in school, how do I ask that question without becoming offensive or without offending the physician or the advanced practice provider that I'm asking the question to? A third strategy that you can use, and this one is to kind of help you as a nurse improve your knowledge and confidence so that you don't feel sick coming to work because you're kind of anxious and you're not really sure about expectations. So again, most novice nurses will tell you that it takes them 18 to 24 to 36 months to get to that comfort zone where they're not scared that they're going to make a mistake and maybe not do the best thing for the patient. And one of the important things to do is ask yourself, am I looking after myself? Am I acknowledging my emotions and practicing self-care? And another crucial element that I'll add into that is, do I feel supported by my coworkers during the time when I'm transitioning from learning from learning how to do one skill to perfecting it? So you got to feel that support, and you have to know how to let somebody know when you're not feeling that kind of support. The other thing is knowing when to ask for help and knowing how to ask for help. And I think I mentioned that earlier. One of the things that a lot of new nurses have reported in what I'm doing right now is because they're experienced nurses, so you can imagine they're experienced nurses with maybe 2-3 years of experience, but walking into a new program, a new arena, and feeling like they've just graduated from school. They know how to give report, but giving report in this area is a little bit different than giving report if you're doing general medical surgical nursing, because we're teaching them to go from being a nurse generalist to an oncology nurse specialist for all practical purposes. So they have to learn how to give report in a different way. You got to make sure that your thought process is organized, that you're not leaving out important details so that the person that you're giving report to in person or on the phone is not becoming frustrated because you're having to stop and go back and gather pieces of information. And again, like many places, we've assigned preceptors or nurse educators to help our seasoned as well as our new nurses with this part of the process, because in just a few minutes when I go through neutropenic fever, you'll see why this becomes real important. So if we can switch to that slide, and so I can go over that with them and not take up everybody's time.
I think, and I think we should be ready for our Q&A now,
Okay,
so we
okay.
don't run over in time.
All right.
And we want to thank you, first of all, for your presentation and for giving us that insight that is very much needed. And as you were mentioning, right, it's not the same, even when sometimes we have experience in nursing, or even if we have experience in oncology nursing, is starting in a new area and starting with something as specific as bone marrow and stem cell transplantation takes time. And I think that the aspects that you've discussed are incredibly relevant. So thank you for that. But we already have a few questions in the chat. The first one from Georgia, Christodoulou. She mentions that in the hospital where she's working at, and exactly the oncology department where she works at, they are trained in less than 1 month to work and manage oncological patients in their medicine. So, I mean, that's not much time. What do you have any advice for this type of situation?
1 month is not a lot of time for training. Ask her when they take their chemotherapy class, are they doing the traditional chemotherapy class that ONS offers, or do they have additional support in terms of chemotherapy and immunotherapy?
So Georgia, I don't know if you can answer that for us and message back on the chat. The one thing and that we need to remember, this audience is primarily European. So
okay.
we don't usually use the ONS courses.
Okay.
And the European Oncology Nursing Society has done some studies as well, because there's a big discrepancy in the education and certification processes for nurses being able to administer chemotherapy. And in some places it's a little bit more strict than in others.
So what I would tell her was that 1 month, just considering 1 month is only 4 weeks, that truly is not enough time to for that nurse to even know what she doesn't know. I mean, you don't know what you don't know until you get in that situation. So at a minimum, in terms of just just teaching people basic education, even terminology. A lot of times, that is what we started with here, was terminology, because we all, is a bone marrow transplant the same thing as a stem cell transplant? Just making sure we're all on the same page, learning to refer to medications, either by brand or generic. For the most part, we use generic. So what I would suggest to her would be to get a reference manual. Sometimes we have a difficult time having a book in our pocket. Tell her, please, to do that. There are plenty of resources out there that are pocket manuals that he or she should not be afraid to utilize. There is nothing wrong with saying, I'm not sure what you're asking me, but I can look it up. I've got this book in my pocket, to make sure that she always has a pen and a paper to write that question down that she doesn't know the answer to, because she will hear it again, or he will hear it again. But I agree. A month is not long enough to train.
And that is the reality of a lot of nurses in many countries. And precisely regarding what you were mentioning, right? Some resources, some materials. We have another participant asking us, would you be okay with sharing some of your contact information? So maybe you can give them some of these materials, or otherwise, if you send me some materials, I happily be sharing those resources with our participants today.
Absolutely. I will send you a list of references that we use, as well as books that they can purchase, as well as things that they can go online, resources that are free. So I'm happy to send that to you. And you can get it. You have a way to get back in touch with everybody that is participating. Okay. So yeah, absolutely.
We should have, I believe we should have everyone's emails. So I would be happy to just forward that information to everyone's emails after the session today.
Okay.
We had another question in the chat as well. It was from Elida. She was asking, how do you cope with the stress in your clinic? What methods do you try?
Okay, so let's talk about healthy ways to cope with the stress in the clinic. I think probably the best way to handle stress is to make sure that you have a mentor or a preceptor, and if one is not assigned to you, whether you can find one in the place where they're working, you gotta find a mentor, whether you find that person online, through professional organizations, but you have got to find somebody that you can bounce things off of, because there's nothing worse than feeling like maybe you didn't do the very best for a patient, because the whole reason that any of us are in this field is because we love taking care of people. We want to help folks. So you have got to find that person that you can run things by. And the reality of it is the people that you're working alongside of may not always have time, but you've got to find that educator in your hospital, or the trainer, or even somebody that you may know, one of us on this panel, that you can always send a question to, or ask, how would you handle this situation, or what should I've done differently? But I think first and foremost, you got to know what your skill set is. And even when you take a job, you in order to protect yourself, you got to let people know what you are and are not comfortable doing. Like I said, 1 month of training. We've been doing this I've been here a year, so we've probably been training for 6 months. Not that they're not still working and taking care of patients, but it's going to take some time.
And I think that is very important to just let everyone know whenever we are new somewhere, these skills are not obtained in just one day. The situation in every country, in every hospital is going to be dramatically different in, the basic nursing education they've received. So I think that everyone who's already here participating in these kind of webinars, they already have that attitude. You're looking for things to do. So I just want to say, tell all of you out there that you're doing a good job. Give yourself time, and continue to look for those resources through the European Oncology Nursing Society. We have some resources available. And then Daniel soon will also be talking as he is with the European Bone Marrow Transplant Organization. So I'm sure he will also be able to give us some new resources. But yeah, thank you everyone for participating, and thank you everyone, and especially for your insight. We are a bit constrained with time. So
Okay.
I'm going to give the floor now to Dimitris.
Okay.
He's my co-chair in the Early Career Nurses Working Group at EONS, and he will be chairing this webinar with myself as well, and introducing as I said, our next guest speaker.
Thank
Dad.
you.
Thank you, Irati. Thank you, Anne, for your great presentation. And we will move forward to our next speaker. I'm delighted to present Daniel Kisilewski. He's an advanced practice nurse in the field of hematology and stem cell transplantation at the Klinikum Stuttgart in Germany. Daniel is passionate of promoting high-quality care based on scientific evidence and patient needs, with a focus on interprofessional collaboration as well as quality improvement interventions. As Irati said, Daniel is the next generation nurse representative from the European Bone and Marrow Transplant Society since 2022, and we are happy to have him with us today to present the basics of stem cell transplantation. So Daniel, the floor is yours, and thank you in advance for being with us.
Yeah, so thank you very much for this warm welcome, and thank you for the opportunity to present some basic concepts and must news here at the EONS Nightingale Challenge. So just let me share my screen. So now you should see the presentation.
Yes, we can see.
Perfectly. All right, so conflict of interest, I have none. Today we'll look at different aspects of bone marrow transplant and stem cell transplant, and with a focus on indication, treatment course, stem cell collection, donor selection, and also on complications like GVHD. Why is this topic maybe interesting and important for young cancer nurses? Understanding the basics of stem cell transplantation helps you navigate the challenges these patients face. You need to recognize early warning signs of complications like infections or graft versus host disease, and know how to act quickly. It's not just about clinical skills, it's about offering reassurance and education to patients and families during one of the most vulnerable and challenging times in their lives. By building this foundational knowledge, even if you're not working in this field right now, you'll come across patients who already had transplant or are going to have it. So maybe you have now the opportunity to gain first insights and grow first understanding of this vital field of hematologic therapies. And if you look at the diagram, transplant numbers are rising in Europe. We had a little dip in the COVID pandemic, but numbers are still rising, and so more and more patients are out there, and maybe you run over them at one time or another. It's basically hematopoietic stem cell transplant is an important therapeutic option in malignant diseases like AML, acute myeloid leukemia, or ALL, but also in other situations that can be applied, for example, in solid tumors. And you see an overview of the indications in a few minutes. Stem cell transplantation is a highly specialized treatment that demands an exceptional level of infrastructure and care. And it's conducted mostly in specialized treatment centers, which are equipped with advanced facilities like nearly sterile isolation units and the state-of-the-art labs for HLA typing or stem cell processing. And these centers are designed to protect the immunocompromised patients and ensure very high safety standards. And this therapy also relies on a highly trained interdisciplinary team from transplant specialists and nurses to lab technicians and support staff. And the intense care and monitoring demand low patient to staff ratios. So stem cell transplant in the end is a very expensive treatment involving costly procedures, medications, and long-term follow-ups. So despite the high costs, these efforts are really crucial to delivering this life-saving therapy to those who are in need of it. Stem cell transplant is a multi-step process aimed at restoring or replacing the patient's hematopoietic blood-forming system. And the process begins with the collection of stem cells, which can come from different sources like bone marrow, peripheral blood, and umbilical cord blood. And following this, patients undergo intensified anti-tumoral therapy, such as high-dose chemotherapy or radiation, to eliminate malignant cells and prepare the bodies to accept the new stem cells. Once this preparation is complete, the collected stem cells are infused into the recipient through a central venous catheter, similar to blood transfusion. The ultimate goal of this procedure is the repopulation or replacement of the hematopoietic system, allowing the patient to generate healthy blood cells and regain a really functional immune system. And basically, there are three categories of stem cell transplant, which is autologous stem cell transplant, allogeneic stem cell transplant, and syngeneic stem cell transplant. And we are going to look at autologous and allogeneic stem cell transplant. So now just a short glimpse on the autologous stem cell therapy process. And here, patients get a remission-inducing chemotherapy, which is in some cases associated with radiation therapy, so that all tumor cells will be eradicated. With a few days or weeks after that, stem cell collection takes place, and this is done by apheresis. So the stem cells are collected out of the peripheral blood, and after that they get cryopreserved, so they will be frozen for an amount of time until the patient is ready for receiving these cells. And the preparation for receiving these cells is a myeloablative high-dose chemotherapy, which takes action against remaining tumor cells and makes place for the stem cells in the field of allogeneic stem cell transplant. And after the reinfusion of these cells, the main aspect is supportive therapy and also psychosocial support for the patients to recover as quickly as possible. And in this field, the curing aspect of the therapy is the high-dose chemotherapy, and stem cell reinfusion only acts like a supportive therapy, so a faster recovery after transplant. And this concept made it basically possible to treat patients with escalated doses of chemotherapy to foster remission, and which otherwise would be lethal without the stem cell rescue. And furthermore, it allows faster recovery after high-dose chemotherapy, so the neutropenic phase is shortened to around 5 to 10 days. And autologous stem cell transplant is mainly used in diseases which are in which the bone marrow itself is not the driver of the disease, or where it hardly is involved in the pathophysiology of the disease. And this is often the case in, for example, non-Hodgkin lymphoma, in testicular cancer, or even in autoimmune diseases. Autologous stem cell transplant is applicable. Stem cell transplant serves as a critical procedure for patients with life-threatening diseases like AML by enabling the replacement of the hematopoietic system through the transfer of hematopoietic stem cell transplant from a compatible donor. And this complex therapy relies on the histocompatibility, which ensures that donor cells are closely matched to the recipient's immune system to minimize rejection and to minimize the risk of graft versus host disease. And the regimens which are needed for that are really intensive. They're that intense that they destroy or damage the bone marrow. So that's the term myeloablative. And these high dose chemotherapies and or radiation eliminate the patient's bone marrow, and which is followed by the immunosuppressive medications which are necessary. And this not only facilitates the engraftment of donor cells, but also suppresses the immune cells of the patient to prevent a rejection reaction. And the aim of this therapy differs a little bit by the disease type. So for malignant diseases like leukemia, the main goal is the graft versus leukemia effect. So donor immune cells actively eradicate remaining tumor cells, which offers potential quick cure. And in the non-malignant diseases, such as bone marrow failure syndromes, like SCID, the goal is the replacement of the immune system or bone marrow, restoring a normal hematopoietic function. Allogeneic stem cell transplant is indicated for a really wide range of conditions where the replacement of the patient's hematopoietic or immune system is necessary. And AlloTX is often reserved for the patients with the severe disease, or for those who lack alternative treatments or where previous treatments have failed. And yeah, as it carries significant risks, it requires careful patient selection. The decision is based on the characteristic of the underlying disease, the patient condition, and the availability of a suitable donor. And here you can see an overview over the whole process of allogeneic hematopoietic stem cell transplant. And we are looking at the most left box with the donor search. So now we're looking at how we identify the best donor. Basically, the main part is HLA matching, and this is a critical factor in the success of hematopoietic stem cell transplant. And it relies on the human leukocyte antigen, which HLA stands for. And these are proteins encoded by the major histocompatibility complex and are used by our immune system simply to distinguish between self and non-self. And these antigens help regulate immune responses, making them essential in determining the compatibility between the donor and the recipient. And for allogeneic stem cell transplant, we are looking at 10 specific HLA markers. And the best outcome occurs when there is a 10-by-10 match. And this significantly reduces the risk of rejection and complications like graft versus host disease. A 9 out of 10 match is still considered a good option, but every mismatch increases the risk for complications. And in severe mismatch situations, like a 5 out of 10 match, which is commonly seen in haploidentical or haplo transplant, additional precautions and therapies are required to improve the outcomes. More than 2 mismatches are associated with a significantly poorer prognosis during the heightened immune conflicts. And there is also a growing discussion about ethnic disparities, because people from diverse ethnic backgrounds often face challenges in finding fully matched donors due to limited representation of their ethnicity in the donor registries. So this really highlights the need for increased donor recruitment across all populations, and therefore to improve access to this, in the baddest case, life-saving treatment for everyone. But not everyone is eligible for being a donor. Donor requirements ensure that the safety of both the donor and the recipients is given. And for that, first donor must meet the age criteria. So typically they are between 18 and 60 years old, which depends on the country you're living in. And in this regard, younger donors are often preferred as the cells are more robust and lead to better outcomes. Sex and weight are also considered, as a higher body weight of the patient correlates with a greater cell. Higher body weight often correlates with a greater cell yield after the stem cell collection, and the bigger the patient, the more cells you need. So you can have a big donor and a small patient, but then the other way around. So that may lead to less stem cell in the collection. And also female donors who have experienced pregnancy may carry antibodies that affect the transplant outcome. So making this an important immunological factor to evaluate. From another immunological aspect, donors are screened for infectious diseases and specific antibodies that might harm the recipient. So ensuring good health is vital, and donors must be free from chronic illnesses or active infections. And lastly, simply, but has to be said, donors have to be available and willing to donate. So this involves their commitment and readiness to follow through the whole collection process. And often donors are not seen in their role as really a critical element of the whole transplant process. So now let's look at the stem cell collection process. In former times, it was really normal to use bone marrow for transplant. And on the left picture, you can see how bone marrow is collected simply by puncturing the pelvis and aspirating the bone marrow. And it's not only two syringes that are aspirated, it's around 20 to 40, and that is really a big number of syringes that were stuck in your pelvis. So this operation has to be with anesthesia, and often patients are in the hospital, or the donors are in the hospital for 3 to 4 days to recover after this procedure. The mostly used aspect in this case nowadays is the peripheral stem cell collection. And like I said, this is done by apheresis. So after stimulating with filgrastim, stem cells come out of the bones, they go into the peripheral blood, and from there they can be collected. And this is simply like a dialysis machine. So in the end, you have this bag on the right side with the collected stem cells. And so normally they are not cryopreserved, but after COVID or while COVID, this was the normal procedure to make sure that both the donor and the recipient are free from COVID, from an active COVID infection. After the collection, the next step would be the conditioning therapy, which is the first step of the main allogeneic hematopoietic stem cell transplant process. Before a stem cell transplant, the patient has to undergo an essential preparation phase to ensure the success of the stem cell transplant procedure. And this phase has 3 goals. Firstly, the eradication of the disease. So you don't want to have any remaining tumor cells in the body. And this is done by high-dose chemotherapy and radiation therapy. This process helps to eliminate the underlying disease and prepare the body for the transplant. The second aim is simply creating space in the bone marrow. So the preparative therapy clears out the patient's bone marrow, making room for the donor's healthy stem cells to settle and grow. And this ensures successful engraftment of the new cells. And the third aspect is the aspect of immunosuppression. So this is done to reduce the risk of the patient's immune system, so donor cells don't get rejected. And for that, furthermore, immunosuppressive medications are used. And these are used to suppress the immune response from remaining immune cells from the patient, so from the original patient. And this improves the chances of acceptance and minimizing complications like a graft rejection. The choice of the conditioning therapy is depending on the underlying disease, so basically its aggressiveness, and the more or less matching donor. So the best sibling, the best donor is a HLA identical sibling, which has a 10 out of 10 match, and the less matches there are. So in the end, the haploid transplant, the more aggressive this therapy has to be. And this is not without side effects. Side effects are really, really extensive in this phase of therapy. So this should only illustrate how many aspects can be involved in this process. And common physical effects like fatigue, nausea, vomiting, immune-related effects like infection, bleeding or bruising, and to emotional and reproductive issues like mood changes and fertility problems. The whole person and his social environment are affected by these symptoms. So this really highlights the need for a comprehensive supportive care during and after the transplant process to manage all these symptoms and furthermore prevent complications which result out of the symptoms. So the next step would be the day 0, how we call it. So until that, it's everything with a minus, so day -7, day -6, and so on until day 0. And that's the day of the transplant itself. And during the transplant itself, the nurse's role is basically to observe vital signs and the patient's status to make sure side effects are recognized as early as possible. Administering pre-medications like antipyretics, antiemetics, and antihistamines help to prevent or at least manage the infusion-related side effects such as fever, nausea, or allergic reactions. And furthermore, many patients, the main aspect of supportive care is providing reassurance and emotional support, as the patients often feel anxious about the whole procedure. And by offering clear explanations and addressing their concerns, we can successfully reduce stress and improve their overall experience. And after the infusion, we have to monitor closely their physiological status. So are there any potential complications like infusion reactions, electrolyte imbalances, or maybe even graft rejection? And symptoms like rash, fever, or changes in vitals should be addressed promptly. The potential side effects and complications of hematopoietic stem cell transplant are plenty, and how you can see in this picture. And it's really a challenging and constantly monitor patients for side effects, as it's dynamic and quite unpredictable when which symptom will occur and to which side effects the symptom might belong to. So that makes it quite challenging and demanding to care for our patients and their families. So from my personal point of view, it's exactly this aspect that makes nurses so important in that field, because we are on the bedside, we see the patient way more often than the physicians, and over time, getting an expert, we might develop really fine antennas to distinguish normal symptoms from the severe symptoms that might be a threat for the patients. And exactly in this point, that's where the expertise comes into game. So predicting which side effect might occur and making sure that patients are secure and the management of side effects starts immediately. And the best example for that is the so-called GVHD, which stands for graft versus host disease. And this occurs when the donor's immune cells attack the recipient's tissues, and the donor's immune cells mistake the tissue as foreign. And there are basically two types of GVHD. The acute GVHD typically is developing in the first 100 days, but the definitions when it's acute, when it's chronic, or if there are mixed forms of it, they're changing from time to time. So that's not the only definition. There are more definitions, but just to have it as a concept, we are dividing it only in acute and chronic. So basically, acute develops in the first 100 days, and primarily it affects the skin, like rashes or redness. It affects the liver, which you can see in elevated enzymes or jaundice, and it affects the GI tract, mostly with diarrhea and abdominal pain. And the chronic form of GVHD typically arises between 3 months and 2 years after transplant, and this kind of affects principally every tissue and every organ. So most common is skin, oral mucosa, eyes, genitals, lungs, and the GI tract, leading to more persistent and systemic issues. And in this aspect, chronic GVHD is not reversible. So if there are symptoms, they will get worse over time. So that's really sure, but you can only use supportive therapies to slow that process down, but you will not stop it. And do I have time left? Yeah, I think so.
1 to 2 minutes if you have done it.
Okay, so I just go over that one. A last concept of stem cell transplant is chimerism. And chimerism refers to the presence of 2 different cell populations within the same individual. So one originating from the donor's stem cells and the other ones from the patient's original cells. And this is a key concept in evaluating the success of the stem cell transplant. So basically, full donor chimerism is defined by more than 95% of the cells in the myeloid and lymphoid lineage in the bone marrow or the peripheral blood comes from the donor. And this is the ultimate goal. So it indicates that the donor cells have fully replaced the patient's bone marrow. If it's less, then we can just watch and wait in terms of mixed donor chimerism, but the transplant physicians will get nervous if it's under 95%, so that requires intensive monitoring and intervention. And if it's below 5%, that indicates graft failure and rejection of the stem cells, and that requires urgent medical intervention. So basically, caring for the patients undergoing stem cell transplant requires long-term collaboration with both families and patients, and that journey spans over months. So you get to know them very well, and from the pre-transplant phase through the post-transplant recovery, it often involves addressing physical, emotional, and social challenges. The complexity of the diseases treated, such as leukemia or autoimmune conditions, and the intensity of therapy regimens demand advanced knowledge and critical thinking. So every patient's situation is unique, requiring tailored care plans to manage complications and side effects. And for nurses and other healthcare providers, mastering this field takes time and experience. So it involves continuous learning and the development of expertise in managing intricate medical procedures. Interdisciplinary coordination and compassionate communication is really key. And the EBMT, so the European Bone and Marrow Transplantation Society, really recognized that and developed some educational materials like the EBMT handbook, the handbook, I'm sorry, that's a typo, the EBMT textbook in English, Spanish, Italian, French, and German. So that's especially for nurses. And the EBMT handbook and the CAR T-cell handbook are on bone marrow and stem cell transplant and CAR T. So these are available for free on the EBMT website, as well as the learning programs, which are in general about BMT, about veno-occlusive disease, about lymphoma, and many more. So if you are interested and want to know more, so just go on the website, download the books, and take part in the learning program. So you will be up to date after that. So thank you so much, and I'll be happy to answer your questions.
Yeah. Thank you so much, Daniel, for presenting the principles of stem cell transplantation. I think we have 2 minutes for some quick questions that we have on chat. The first one is, have there been any adverse reactions noted to the stem cells now being cryopreserved?
Sorry, can you please repeat the question?
Yeah, with the stem cells that now are cryopreserved, are any adverse reactions to the patients?
Yes, of course. So basically, the cryopreserved stem cells are causing the infusion reactions, and the not frozen ones to cause, at most of the time, no reactions. So it's the cryopreservative substance that causes the reactions, and it's I don't know how to spell it in English, but it's DSMO, and that causes allergic reactions like difficulties breathing, a swollen neck, and nausea. So that's why we are giving the pre-medications before the stem cell transplant.
Perfect. And with the introduction of the CAR T-cell therapy in the clinical practice, that sometimes is the gold standard for some cases, which will be the role of allogeneic stem cell transplantation in the future?
So that's a really interesting question, because no one has the answer to that until now. So in the moment, there is the impression that CAR T-cell therapies are rising. So until last year, we had 5,000 CAR T-cell therapies in Europe. 1 year later, we had over 10,000. So the EBMT, the survey on that, and the numbers go up. With that said, the number of stem cell transplants are going up as well, and it's not completely clear how this will develop. Some say that CAR T-cell therapy will gain more ground, and many patients who are now eligible or are elected for a stem cell transplant can receive CAR T in the before allogeneic stem cell transplant. So I think stem cell transplant will continue to serve as a curative options, but CAR T will gain more ground in this field, and I think some researchers say that in a few years we will have equal allogeneic stem cell transplants and CAR T cell therapies, and yeah, we will have to wait for that, because not every CAR T therapy which is researched on is in the market right now. So, for example, allogeneic CAR T cells, which are in the making now. We will have to wait for that.
Okay. Thank you so much. Unfortunately, we don't have any more time for discussion. We would like to thank both speakers, Anne and Daniel, for their great and very informative presentations. And of course, to thank all the participants who were with us in this first webinar. And if we can have the poster for our next webinar. So we hope that we have all of you with us next Monday, 25th of November, for our second webinar, which is about scientific writing and dissemination of results for cancer nurses. We will have two excellent speakers, Dr. Cristina Garcia Vivar and Dr. Marc Dornat, who will speak about this topic. Thank you again. Thank you, Daniel. Thank you, Anne. And thank you, Irati, for today's webinar. And see you all next Monday.
Thank you too. Bye-bye.
Thank you, bye.